Inside a human host, a systemic bacterial pathogen does one thing: it divides, multiplying its ranks to overwhelm the body's defenses. The instinctive medical response might be to flood the system with the highest tolerated dose of an antibiotic to wipe them out. But efficacy isn't driven by the sheer volume of the drug. It requires engineering the drug's exposure over time to match the specific vulnerabilities of that target bug. We measure that vulnerability using a foundational metric, the minimum inhibitory concentration, or MIC. By incubating bacteria in progressively higher drug concentrations, we find the exact threshold where the test tube goes from cloudy to perfectly clear, here at 3 micrograms per milliliter. That specific threshold is the MIC, the lowest drug concentration required to prevent visible bacterial growth in the lab. But translating that from a test tube to a human body means watching how that baseline MIC is mapped onto a systemic concentration curve as the drug enters and eventually leaves the bloodstream over time. Finding the MIC is only the starting line. Mastering antimicrobial therapy means manipulating how the drug behaves around that exact threshold to trigger one of 2 distinct lethal mechanisms. The first of those mechanisms is time-dependent killing. For these drugs, pushing the concentration into massive peaks doesn't kill bacteria faster. The rate of bacterial death relies on the duration of exposure. The target here is to maximize the percentage of the dosing interval where the drug concentration remains above the MIC threshold. We see this profile in the beta-lactam classes, which include penicillins, cephalosporins, and carbapenems. Achieving consistent time above MIC is difficult in severe sepsis. Patients have erratic pharmacokinetics. Their bodies clear drugs at unpredictable rates. To solve this, clinicians avoid intermittent boluses. Instead, they run continuous intravenous infusions to lock the concentration exactly where it needs to be. If the concentration drops below the MIC, the bacteria immediately resume their growth, leading to treatment failure and selecting for resistant strains. For time-dependent agents, lethality requires relentless, sustained pressure rather than overwhelming force. The second kill profile operates on the exact opposite logic, concentration-dependent killing. This chart shows how the rate of bacterial destruction increases exponentially as peak drug concentration climbs. The target here is the 10x rule. To achieve maximum bacterial destruction, the peak drug concentration must hit 10 to 12 times higher than the MIC. This aggressive strategy is the primary mechanism for antibiotics like aminoglycosides and fluoroquinolones. But sustaining massive peak concentrations for too long introduces a severe risk of host toxicity, inflicting serious damage to the kidneys. The solution to that toxicity problem lies in a phenomenon known as the post-antibiotic effect. These drugs bind irreversibly to microbial targets, suppressing bacterial growth for hours, even after completely clearing from the bloodstream. This specific delay allows for a high-dose, extended interval dosing strategy, like giving aminoglycosides just once a day. Stretching the interval gives the host's kidneys the necessary time to clear the toxic drug, while the post-antibiotic effect keeps the infection totally suppressed in the background. Combining concentration-dependent killing with the post-antibiotic effect allows clinicians to deliver a devastating strike to the pathogen while providing a biological safe harbor for the patient's organs. Zooming out from the isolated interaction of one drug against one bug, we must account for the vast, complex ecosystem of the patient's microbiome. Antimicrobial weapons are blunt instruments. There is no antibiotic that kills only the intended pathogenic target. A healthy population of sensitive normal flora actively protects the host. They consume available resources and produce inhibitory substances that keep any dangerous, resistant mutants strictly in check. This chart shows what happens during prolonged broad-spectrum antibiotic therapy, the rapid eradication of sensitive protective flora. With that population wiped out, an open ecological vacuum forms. This vacuum selects for the proliferation of drug-resistant microorganisms, allowing them to multiply without restriction. This is a superinfection. It's a secondary infection superimposed on an earlier one, directly caused by the treatment itself. The quintessential clinical example of this failure is the eradication of normal gut flora, which paves the way for the deadly overgrowth of Clostridioides difficile. The broader the antibiotic spectrum and the longer the duration, the higher the mathematical certainty of spawning a deadlier, resistant secondary threat. clinicians are forced to walk a very fine line. They must aggressively eradicate the invading pathogen while simultaneously protecting the host's fragile microecology. Balancing that equation requires a fully integrated solution: antimicrobial stewardship. Rule 1 of stewardship is to optimize the pharmacokinetic strike. This demands matching the drug class to the correct dosing strategy, like continuous infusions for time-dependent drugs or high-peak daily dosing for concentration-dependent drugs, ensuring maximum lethality. Rule 2 is to minimize the ecological footprint. That requires prescribing the narrowest spectrum agent possible for the shortest effective duration to prevent the ecological vacuum from forming. This coordination allows clinicians to replace generalized protocols with pharmacokinetic math tailored to both the unique pathogen and the patient's specific organ function. Mastering the kill curve is the only way to ensure the immediate survival of patients today while protecting the viability of our entire antibiotic arsenal for tomorrow.